Before that, I'd like to make a disclaimer. Yeah, I work with UKM. Whatever that is expressed here is, of course, my own experience, my own opinion, and I also do not represent the organizer. Right. So this is UKM. We are based in Cheras, the hospital UKM, right? Is now renamed as Hospital Chancellor Tuanku Muhriz, if you wonder. Okay, so this is the team that we had. Of course, it has now grown even bigger. This was taken when I was the head. Okay, let me start by sharing with you a little my own journey. I started my career in research with the interest to, most of us want to make a breakthrough and we want to contribute to humanity, through medicine. And so I started with the debilitating disease, right? Most of us would think cancer would be top of the list. So I did my master's in cancer study, and that was in University Malaya. When I was working with cancer, I think the most, besides finding a cure, we were trying to see whether we could detect cancer earlier. So I was working on identifying what marker is associated with how severe a cancer can be, meaning how aggressive a cancer. So this is where I stumbled upon telomere and telomerase. So cancer, most of us would understand that it arises from our cells, right? And it became very clever that it has breakthrough the regulation of the body and has started to become selfish, and it starts to grow and grow, depleting the resources that were supposed to be shared. So I hope you can see this as very reflective of the society, right? Look at your body as a society. So if someone wants to break the norm and become very self-profiteering, so this is cancerous. And when we take the cancer cells outside from the body, they can almost live forever if you can continue to feed them. So they are immortal, right? So this is also not the norm. Most of us don't live forever. So taken any of your healthy cells out of your body and grow, they cannot grow forever even with the best condition. Okay, and with all the food that you feed them, they won't grow forever. They will age and die. But cancer cells has cleverly turned on a gene to express the protein called telomerase. By doing that, it allows it to grow and grow. So I will explain the science of it later. So that the lessons that I learned from cancer is that they are immortal and they can grow perpetually given the right condition, and telomerase activity are often activated. Of course, not all cancers, they have different mechanisms to grow forever, but telomerase activity it's turned on in most cancer, and it correlates with how aggressive the cancer. So the more metastatic the cancer is, the telomerase activity is higher. And the cancer cells have telomere length that is short, but they maintain it to be short. Okay? It will make sense. It will make a lot of sense to you when I explain it later. But little does the cancer know, probably predict that if the host die, they die too, right? Okay? So that is why in a society, so when we have, at the end, if the society collapse, then there would be no peace and happiness anyway, right? So that's the lesson that we learned from the cancer. But I was then interested in pursuing regeneration because I believe that we have the ability to heal. Do you agree? We all have, right? But somehow, as we age, probably that ability has decreased. Our body defense has weakened. And so how do we find that again? How do we restore that again? That's where I went on to do my PhD in stem cell and regenerative medicine. So in what you see on the slide here, this was a breakthrough many years then. It was at the turn of the century, around year 2000, end of 1990s and year 2000. These pictures came and was very horrified. I think people were horrified. We are making human ears behind, in animals. But what it's trying to show you is that we can try to make tissue parts from your cells, okay, to grow them and fashion it so that it can be used to replace damaged tissues or organs. Okay. So this is called tissue engineering, and simply tissue engineering. So this tissue engineering has a general concept of. The general concept is we get cells from your body, but in fact it can be also donor. But the best is from your body so that we can avoid rejection of the cell, the tissue that we're going to make at the end. So we take a part of a biopsy from a body, and we will isolate the cells and we expand the cells in outside the body given the best condition. So this is the chance where we would probably even enhance its property. So we rejuvenate the cells, we enhance its health before we give it back. So and most of our tissues has got a certain structure. So we will combine that with certain biomaterial, which we call it scaffold. And with that, we mature it further, either with some in a bioreactor before giving back to the patient. So this is general the cycle of tissue engineering. And here I'd like to show you what is possible when we grow the cells in the lab. Here we were trying to grow nerves, so we make them align and so that they are unidirectional, and we grow them in nanofibers because in that is the environment that the cells love. They like to anchor themselves on nanofibers. Okay, and the others are the other kind of scaffolds where you'll be surprised. In fact, the environment will dictate the behavior of the cells. So by changing the environment, I'm using some random fibers and aligned fibers. It changes the kind of genes that are expressed in the cells. So simply, I'm just trying to say that when the cells are taken out of the body, we study them and we understand them more, and we understand that they are very responsive to their environment. All right. So to give you a snapshot of the kind of tissues that we have engineered, we have cornea, we have made cornea, we have made nerves, we have even regenerated bladder, a full bladder. We have taken a subtotal resection of the bladder, and we were able to grow the whole bladder. And we make bones, and we even make them injectable. So that's a CT scan of how the injectable bones were able to grow. So these were all done in animals. So this is a stage of research where we always try it on animals. So we must thank the animals for sacrificing for this cause. And we went on also to customize them because everybody would have different tissue damage, right? The shape and sizes. So we use CT scans and with now 3D printing, we are able to customize and make the shape specifically for you. So this is an example of a bone that we customized for the sheep, and we were able to really make new bone for a very big gap, a bone gap in the sheep. Okay, then we make cartilage too. Just now, Tan Sri mentioned about OA. So we do this in sheep. And most of us are told that when you damage your cartilage, it would never really grow again, which is really quite true. Why? Here I'm showing you a picture of if you can see the word control and cartilage the other side. So control is where we didn't do anything to the knee. There's already a defect, and the other one we plug in our engineered cartilage. And although the other one looks nice and smooth, right? But when we look further, we study further, they are just scar tissue. So it would not have the mechanical property that you want for your knee cartilage. Whereas the other one has got we say gag protein. You always take take supplements, right, to enhance that kind of protein. So that shows that, with the technology, the engineered tissue, that they are able to regrow high-lying cartilage, the cartilage that has the property that is appropriate for the knee. All right, then we also went on to do injectable. So because we are always innovating, hopefully that it will be less invasive. And again, here we are demonstrating this in sheep, and I will just show you the very last slide, last photo there. The cartilage, the new cartilage that you see, the red layer, are the cells that we injected because we tracked them with fluorescence, and they were making the new cartilage. So this is the direct evidence to show that the cells that we injected has grown into the new cartilage. Okay, so then we went on to do clinical trial. I will just show you 2 trials that we have embarked on. This was done way back in 2016 and completed around not even then, maybe earlier, 2012, and we completed it probably sometime in 2016. Since this is an engineered skin, again we took tissue from the patient, a piece of skin, and we can make many pieces of skin. So our first patient was, in fact, was just a clinical study. Was a girl who had sustained 34% burnt. So when she came in, she was in sepsis. So one of the problem when you lose skin is you will dehydrate, you will dry up, and you will get infection, right? Because you have lost the protective barrier. And after stabilizing her, there was very little skin that we, usually what we do is we will take the healthy skin from elsewhere to patch up, right? But it was so extensive that, you will be harvesting a lot of healthy skin for this little girl. So the surgeon come to us and ask for help. And with that, we make, in 3 weeks, we make 6 pieces of skin for her. And this is how it is. It was, she got burned almost the entire body, the leg up. Okay, and and this is how it looks like. And it was not just only our skin, so it was a mixture of the skin graft that they took from elsewhere, because if otherwise they have to wait a long time. We make a lot of skin. We need longer than 3 weeks. So with that 3 weeks, we make 6 pieces. So there is a mixture of split skin graft and the skin that we engineered. So how do I differentiate it? Split skin graft will have that texture. You can see it has that bumpy structure, and eventually it will have contraction because they are already mature skin. So it will come with that texture. Whereas the engineered skin, because they are young, they are like baby-like. In fact, they are color. They don't have melanin. We didn't put in the melanin. We only have keratin, the 2 types of cells in there, and it's thin and smooth. Okay, so that's how you can differentiate the split skin graft, the engineered skin. But what is most important is the girl was able to celebrate her birthday, I think 1 month after implantation. So we celebrated birthday together with her. So it was actually a very rewarding experience. And we went on to do a proper clinical trial. This is a trial phase 1/2A, and we had 10 patients. So I forgot to mention that the girl actually received treatment before she came to UKM. So there's actually an unmet need that, where regenerative have a place. I really feel so. And this is also another case. So during trial, this patient had already had his split skin graft. So he was also a burn patient, a teenager. He's probably in his 11, 12, because I remember during that time we actually brought teacher to the ward so that he can continue his education. So it was so bad. His earlier experience was so bad, he developed psychological problems as well. And so during that, so we made the skin for him. I can't remember how many pieces, but what you see in day 150 is supposed to be healed, but he went on he was on a motorbike and he fell. He got hit, and so there was another trauma there. Otherwise, it would have healed earlier. So I mentioned he had received split skin graft before he came to UKM. So therefore, again, you would see the contraction would be coming from the split skin graft, whereas the smooth one comes from engineered skin. All right. So then we also treat skin traumatic injuries. And so sometimes they come with multiple injuries. So before the bone healed, the skin has already healed, okay, using the engineered tissue. And we also treat diabetic patient. But I must say, the diabetic patient was really a challenge because, our skin graft is very rich, colonization of bacteria is another problem. But according to the plastic surgeon, by the time it reached day 19, the wound bed after a treatment with engineered skin was so good that she could do a simple a simple split skin graft and it take on. So sometimes a deep wound, before that he had very deep wound, if you can see here, it would not be able to take on the split skin graft anyway. Okay, so and for bone we use cells from the patient, and this time we take it from his marrow, and the cells that we isolated were mesenchymal stromal cells. And again, we have to combine that with a scaffold. In this case, it's a ceramic. And so this is the patient. Again, he came after receiving treatment. He had a motor vehicle accident. He was in his 20s, but he has been in wheelchair more than a year. And because his bone just could not unite. Even he has bone graft, it just did not perform what we thought what the surgeon thought it would. So you could see that it did not unite properly, and the patient didn't want another bone graft. He said it was painful. And so he came to us, the surgeon came to us and see if we could do compassionate therapy for him. And so we did. So we 3D print the scaffold according to his bone defect, and that was me. Okay, so we grew the cells, and finally we implanted it. And this picture was taken years later. He was back to work. I've met him again last year. It was already 7 years, so I said for 7th anniversary we should meet. So we met, and he got married, and he even have a child. So it was again very rewarding to see patient able to walk again. So since Tan Sri has already explained the stem cell, and with time constraint, I would not really need to go into detail. But important, I think, because the word stem cells has been used or sometimes abused. Everything is called stem cells. So if stem cells come in a bottle to you, they are not stem cells because they can't live like that. Okay, they come out of a pocket. It can't be stem cells. They are alive. They are living cells. They can only be alive in two conditions. Either they are in our lab in those special incubators with a temperature, and they are immersed in some liquid and sterile liquid, where it is food to them, or they have to be in minus 196 frozen. All right, so that are the two forms that can be alive outside your body. Okay. But importantly, stem cells are cells that can turn into many other types of cells, right? Okay. And also Tan Sri has already mentioned, but I really like to point out that there are different types of stem cells. So if anybody tells you stem cells, ask them where is the source of the stem cells. Where is the source? Because the source dictates how potent or how risky these cells are. So if they are taken from the embryo, usually it's a no, just because it can turn into a human, right? But if it comes from a blastocyst, it's also embryo. Usually it is at the point where how we get it is from surplus egg after an in vitro fertilization procedure. You have extra eggs. Some couples do donate for research, and that's where we can get some cells out, the inner cell mass from there, and we can grow the cells. And these cells are called pluripotent. They can grow into everything, but not a full human. Okay, so that's pluripotent cells. And when we take it from baby, like your cord blood or your cord, placenta, they can only be multipotent, meaning they can turn into limited things, okay? Limited tissues. Not every tissue, but limited tissues. And the good thing is, we have now discovered the way, because you can imagine, we all start with one cell, right? We all start with one, okay? With the genetic blueprint, right? The same genetic blueprint. And from there, we make many more cells from that one. So, it's about the cell has gone through programming, okay? And so we have found a way to reprogram the cells, and it turn into pluripotent cells again, which is almost similar to the ones that we get from the surplus egg. Okay? And when we say turn into pluripotent cells, means it can make all the tissues, the more than 200 types of tissues in your body. I think the most precious one is brain cells. Brain cell. Okay? So the technology is here, but how to reduce the risk? Because one of the signature of a pluripotent stem cell is, if I implant the pluripotent stem cells, it must form teratoma, which is a kind of tumor. Okay, so that is the signature. So how can we make sure that we have to turn 100% of them into the cell or into the tissue that we want, and not into anything else? Okay, so that is the risk. Okay, so you may ask, so in an adult, where do we get our cells? Just now I did mention that we can get from bone marrow, you can get from your blood, but there are different types of stem cells. Got blood stem cells, got mesenchymal stem cells, and mesenchymal stem cells is, I work a lot with these cells. So we can get it from various sources, even from your fat, okay? So it's good to keep some fat, maybe that is your reserve, okay? So fat, you can get it from apheresis, meaning from your peripheral blood, but of course it has to be induced to give more of the MSCs, okay? It can also from the wisdom tooth, okay? Baby tooth or wisdom tooth, we have already isolated cells, and they are very potent too, okay? Alright, so this is just to show you that, when you grow these cells, they all grow at different rate. Now, this is how the cells are in our lab, okay? The younger they are, the healthier they are, they will grow faster, right? Okay. And so this is where I'm going to explain, I promise you I'm going to explain this, right? So, alright, so I promise you I'm going to explain this telomere. So we are all born, when we are born with, we are already in, how to say, it's sort of imprint that we have a biological clock. It's determined by the length of our telomere. So telomere is the end of your chromosome. So your DNA is packed as chromosome. So we have 46 chromosomes in every cell. So this is one example. So at the end, there is like buffering zone. There's a buffer of DNA material that is a buffer. Why I say buffer? Because every time you have to grow, when your one cell grow to another, split to another cell, grow into another cell, it will have to replicate the DNA, right? Have to photostate the DNA so that the cell would have the same set of DNA like your original cell. So every time it replicates the DNA, it cannot replicate the whole thing. Now you can imagine if I'm a train, the cabin of the train. So I must park first. So the place that I park is not replicated. If you understand, so meaning if I replicate, there will always be a strand that where I dock, and it's not photostate lah, not photostated. So that every time it replicates, it will shorten. Every time shorten. So probably 50 to the maximum 80 times, then your cell will be too short that the genes, the critical genes are affected, then your cell will die. So that's why I'm saying, I said just now that your cells are programmed to die. Okay, they will not live forever. But cancer cells has this ability to turn on the telomerase, which grow the telomere. Okay, it grow the telomere, and so it's able to keep replicating. But it says here, what I'm trying to say is the telomere length can be somehow correlated with how long you live. Okay, when you are early in life, your telomere length tells you that. But eventually, when you grow older, we measure your telomere length. It no longer predicts lifespan. Why? Because many other factors come in. All right. Okay. So the other factor that I will introduce is epigenetic. This is another very deep concept, but I'm afraid that with the time constraint, I'm not going to really go in length. But I just want to, your take home is that you are determined not just by your genetic makeup. Your epigenetic plays a big role, meaning your lifestyle. Your lifestyle affect how your genes are expressed and not expressed. So as you grow old, there is signature that some epigenetic changes will happen, meaning outside the genes, that is going to stop some genes from expressing, make some genes express more. So that is called epigenetic changes. And this is the picture of a young cell and an old cell. As the cell grow old, you see, they don't look so vibrant anymore, and in fact, they accumulate rubbish inside their the cell. It becomes blue, and eventually it becomes inflamed, and that's why you have chronic inflammation when you grow old. Okay, so and part of it is because your epigenetics changes, and it no longer it's very loose. I'm just showing here. The epigenetic changes allow some of the tumor suppressor genes to be not suppressed anymore, for example. Okay, so that's why cancer may occur. So these are the changes, and we found that by looking at your epigenetic changes, we can predict your lifespan better. So what I'm trying to emphasize here, what determines the epigenetic is not inherited, but it's your lifestyle. Okay. I really think I have to skip all this. Okay, I don't have the time to talk about mitochondria and all that. But I want to come to my second last slide is, let's focus on health span, not just lifespan. Right? Just now I told you that there's a limitation, but we can live healthily. When we have to prioritize living healthily during our old age, and that is very possible with regenerative medicine. Okay, so what are the things that affect your epigenetics? This is what I really want to emphasize. Exercise, environmental factors, of course, contamination and all that, try to keep away from there. Your diet, and another one is socialization. So when I mentioned this to Tiong, he was very happy. He said, "Oh yeah, no wonder old people has to get to be around young people," which is very true. Okay, social network is very important, and all that affects your epigenetics. Okay, so I hope that's good news to you, because all that is practical and is what you can do, and it would have a long-term biological effect. Okay, so my conclusion is, you understand what aging is not scary, okay? Then you would be able to choose the better intervention, and understand the logic behind your intervention, the treatment that you want to take. Go for there is proof. Go for the theory is sound, and then there is proof, maybe publication or what, and there is actual clinical trial. There's data from the trial that they have already done, and again, my message is, let's focus on living healthily while aging gracefully. All right. With that, I thank you very much.